question, you may press the 1 followed by the 4 on your telephone. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press the star followed by the 0 on your telephone. As a reminder, this conference is being recorded today, Thursday, August 18, 2011. I will now like to turn the conference over to Ms. Amanda Hopping-Wynn, Project Analyst. Please go ahead, Madam.
Thank you. Hello. Welcome to the third teleconference in our 2011 series. I'm Amanda Hopping-Wynn, Project Analyst here at the National Abandoned Infants Assistance Resource Center located at UC Berkeley. Funded by the Health and Human Services Children's Bureau, our mission here at AIA is to enhance the quality of social and health services delivered to children and their families affected by substance abuse and/or HIV by providing quality training, information, and resources to the professionals who work with these families. On behalf of the Resource Center, I'm excited about today's presentation, The Effects of Stress on Parenting and Related Child Outcomes in Families Living with HIV. Our first presenter, Debra Murphy, is a research psychologist and director of the Health Risk Reduction Projects within UCLA Integrated Substance Abuse Programs. She's conducted HIV/AIDS behavioral research on children, adolescents, adults, and families over the past 19 years. Dr. Murphy is currently principal investigator on 2 NIMH-funded R01s. The first is to assess the impact of maternal HIV/AIDS on late adolescent, early adult children in what will be a 15-year longitudinal study, as she has followed these families since the children were 6 to 11 years of age. The second is to test the preliminary efficacy of a parenting intervention for HIV-infected mothers with well children aged 6 to 14 years old. Overall, she has been the principal investigator on 9 federally funded grants and 3 state-funded grants, as well as a co-investigator on 18 federally funded projects. Prior to coming to UCLA, she was the associate director for the Center for AIDS Intervention in Wisconsin and co-investigator on a series of federal grants focused on outcome evaluations of HIV behavioral risk reduction interventions. Dr. Armistead has investigated the impact of various family stressors on child and adolescent functioning. More recently, her research focus has narrowed to the intersection of HIV and families. In particular, she investigates the impact of maternal HIV infection on children. She's conducted this work domestically with African American families as well as internationally in South Africa. Through this research, she and her colleagues have identified several family process variables that serve as mechanisms through which a mother's illness affects her child. The second focus of her recent research is the prevention of HIV via family-based methods. She helped create a parenting-based intervention for families of 9 to 12-year-old African American children, the Parents Matter program. The Parents Matter program provides parents with tools to keep children on a healthy trajectory and free of HIV and other STDs. Before we continue, I would like to quickly review a few logistical reminders. As Nelson, our operator, said, if you are participating in the web portion and at any point have a question, you can type it in the chat box located in that bottom left corner of your screen, and we will take those questions at designated breaks during our presentation. In addition, if you're participating by phone only, there will be an option to call in. You would dial 14 and you'll be placed in queue for questions when we open the line. If at any time you need assistance, you can dial *0 and a Ready Talk operator will be on the line with you. And at this point, I would like to turn the call over to our first presenter, Dr. Debra Murphy.
Hi, everybody. Today I'm going to be talking about the effects on parenting skills and child outcomes of moms' anxiety and stress, moms who are living with HIV. And if any of you have any follow-up questions, in the coming weeks after the talk, I can be reached at UCLA. I'm in the UCLA directory. So I'm going to briefly discuss 2 studies today. The first one is my Parents and Children Coping Together study, referred to as the PAC study. The second one is the Teaching, Raising, and Communicating with Kids study that I've finished recently. It's referred to as the TRACK study. So first, PACT. PACT was first started in 1997, and we started following children whose mothers had HIV or AIDS, and the children were 6 to 11 years old at the time that we started following them. We wound up publishing quite a bit on that study, and were very productive. So we towards the end of that one to continue to follow the children as they transition to early and middle adolescence. And that became the Parents and Adolescents Coping Together study, PAC2, which went from 2002 to 2007. And again, because that one was very productive and we continued to learn a great deal from the families, both the mothers and the children, we applied to follow them one last time as the children transitioned to late adolescence, early adulthood. And that study is still ongoing. So this is a 15-year study that will end in 2013, and it's the first cohort of children affected by maternal HIV, followed from early school age to late adolescence, early adulthood. That's been done anywhere in the United States or internationally, I believe. When we originally started the study, we began with 135 mother-child dyads. The moms were, you can see, about mean age of 34 at the time, and the sample, we're here in Southern California, was primarily Latina and African American. The children were mean age of 8 at the time, and it was perfect mix. We had about half females and half males. So there's a number of stressors going on in these families, and at the top of each of these screens, you're going to see the main stress-related construct that I'm talking about. So first, adherence and stress. The majority of our moms living with HIV were on antiretroviral therapy when we recruited them and had very poor adherence. The adherence issues were stress was that was significantly affecting their ability to stay adherent. Having a partner, which did not act as a buffer in this case, or as a social support mechanism, it seemed to act as a secondary stressor. And when you think about it, that makes sense. A lot of these moms, even though they're infected and need to be taking care of themselves, are the caregiver in the family, and they're taking care of partners who are often infected also. And having a young child, there was a trend for that to be significantly associated with poor adherence. Another major stressor that these moms have is disclosure. Disclosure to children is one of the major concerns of these moms. And so a lot of them don't disclose in order to try to protect the family and the children. However, that winds up being a stressor for them also, because they wind up skipping medications so the children don't see them taking them. They're more likely to miss medical appointments. These are all research study findings here. And they're more likely to have greater levels of depression because they have a huge secret in the family and they're continuously hiding something. Another major source of stress for these moms is not being able to carry out what they consider appropriate parenting roles. They feel very guilty when they can't function as well as they would like. For example, in terms of monitoring where the kids are, or conducting regular family routines, which is what I'm going to talk about next. We did a longitudinal study. The average age of the child at the study start was 8 years, and when we finished the study, they were 13.8 years old on average. And what we found that maternal health was strongly associated with family routines. That is, moms who were healthier were able to engage in more frequent family routines. And by family routines, I mean things like having breakfast together, having playtime once a week, doing something special once a week, whether that's going to church or going to visit grandma, having stable family routines that provide a sense of security for the children in the family. And when moms couldn't do this, it had a huge impact on child outcomes, with children in families where there were fewer routines showing more aggression over time, more anxiety, more depression, also more binge drinking, which was interesting. It didn't affect their general exploration of drinking as they aged into the teen years, but it did affect whether they became binge drinkers. I became interested. I had seen a lot of studies done on family routines and their impact on families, although not among families affected by HIV, but I had never seen one done on whether the moms being able to keep family routines stable had an impact. So we took a look at that because since we had such longitudinal data, we were able to look at this over time, and a lot of the studies in this area are only cross-sectional. And we found some amazing results. This is a typical trajectory for one of the children, and you can see that where in a family with stable family routines, where the mom didn't become hospitalized a lot or fatigued a lot or wasn't ill a lot, you have very few, I think this is conduct disorder behaviors, very low levels of conduct disorder behaviors, lying, stealing, etc., your typical conduct disorder behaviors. Whereas where you have unstable family routines, as the children age from 10 up to into the teen years, they had much higher levels of conduct disorder. And I'm not going to show you all of the other behaviors, but this was kind of the pattern we found for many of the other behaviors, anxiety, depression, etc. Okay, I'm going to open for questions briefly, if there are any at this point in time.
Nelson, we'd like to open the line for questions.
Thank you. Ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. If you would like to ask a question, you may also use a chat feature located in the lower left corner of your screen. Once again, via the phone to register a question, it is the 1 followed by the 4.
And we do have a chat question that has come in from Marilee Comfort. She says, how do you define parenting skills?
I define parenting skills as a broad range of skills, starting with parental monitoring, that is knowing where your child is, especially as they get older, knowing what they do with their money, etc. So that would be parental monitoring. I also define it as implementing regular family routines. That is keeping consistent, stable, positive family routines within your family setting so that children have a sense of stability and security. I also define it as appropriate discipline techniques, and there are a broad range of measures on this, but there's a lot of literature indicating what are appropriate positive parenting techniques, discipline techniques that work versus those that aren't. And I would say there are other types of concepts that can be subsumed under parenting skills, like the type of family functioning style you choose to run your household, etc., that I think that impact parenting skills, but are not a parenting skill in and of themselves.
Thank you. Nelson, do we have any calls on the line?
I'm showing no questions over the phone.
Okay.
All right, I'll continue then.
And pardon me, it's a pleasure for the introduction. We do have somebody that just queued up right now. It's
okay.
Chris Ezzoletti with Santa Cruz, Community Council. Please proceed.
Yeah, I have a question. What's the average of the socioeconomic for the groups that you study?
What is the average socioeconomic for the group study? I just want to repeat it because it was a little quiet on our end.
Yes, these are all moms. Most of these were single parent mothers. Most were not married, did not have a partner, and were living at what would be considered poverty level income. When this study started back in 1997, I believe the average income ranged from $14,000 to $20,000 a year. It's slightly higher now. We've continued to measure it every year, but it's stayed at poverty level just with inflation rates.
Okay.
Okay, I'll move on. So all of the factors I've discussed so far that can cause stress to the moms have a huge impact on how the children turn out. For example, I used the example of family routines a few minutes ago. What I think is another huge stressor for these moms is that mothers are often aware that the children are being impacted, as you can see by some of the quotes we've collected in our qualitative work. One mom said, "You feel useless. You can't cook for your kids, take care of them, take them out. It was frustrating. Another mother said many times he wanted me to take him to the park, and I was suffering from the side effects of my medicine. He got frustrated, angry. He wanted more attention. Another mother said when they hospitalized me for 3 months straight, I wasn't there for him, and I couldn't. 3 months seemed like not a long time, but it is for his age. He wanted mama, and I couldn't be there. Sometimes the moms are putting their own health at risk, and that's a stressor because they know what they're doing. For example, this mother that said, when I knew there was something going on, I didn't take the medicine. Holiday school events, things like that. I don't take the medicine because if I take it, I'm going to be sleepy, I'm going to have diarrhea, I'm going to be nauseated, dizzy, can't drive, pain in my legs, all that. So they put their own health a little bit at risk in terms of not being on their medication schedule in order to do things they want to do with their kids so the kids aren't frustrated. And a final quote, one day he came home from school and told me, Mommy, I'm going to tell you something. Sometimes I am at school and I'm thinking about the hospital and what is happening to you. That is happening to me a lot. So the moms are seeing anxiety in their children, aware that their health is causing it, and that's a burden for them. That's a stressor for them. Again, any questions at this point?
Nelson, we're going to open the line again for questions. Dr. Murphy, I have a question. You had mentioned that medication adherence was very poor among the mothers in PACT. Do you know the actual adherence rate?
When we started the study and did the initial adherence rates on the moms, it was very low. By pill count, it was only 43%, which is horrible, since you need about 90-some% to get viral load suppression. And by self-report, they thought they were doing a little better. They said it was about 56%, but I would go with the pill count measure because that's the more objective measure. So we had very low rates where these moms were not suppressing their viral load and becoming more ill over time because of that.
Nelson, do you have any questions on the phone?
Kate, once again, as a reminder to register a question, it's the 1 followed by the 4 on your telephone, or maybe use the chat feature on the web.
And while we're waiting, too, oh, did you have one? Sorry.
No, sorry, I'm showing no questions at this time over the phone.
Okay.
Okay, shall I move on?
You shall.
Okay. I told you I would talk briefly today about 2 studies. The second one is Teaching, Raising, and Communicating with Kids, the TRACK study. This study is a disclosure outcome study that actually Dr. Armistead, the next speaker, and I worked on together. But in this particular piece of data that I'm talking about from the TRACK study, I'm not talking about disclosure. We were looking at maternal stress among the moms because I just talked to you about general stressors these moms have, adherence, being a good parent and implementing good parenting skills, poverty, someone brought up the whole issue of their socioeconomic level. Those are all stressors that the moms are dealing with and have anxiety in response to. But parenting stress itself is a little bit different than these general stressors, and high levels of parenting stress have been associated with negative parenting practices. So it's kind of like a vicious cycle in a way. You have a lot of stress as a parent, and that in a sense that then the stress itself makes you become a poorer parent. In this particular study, we had almost the whole sample was Latina, 81.2%. And again, just briefly, we looked at the mom's parenting stress, their general anxiety, and their HIV health-related anxiety. That is, things like, I'm so worried about my HIV progressing that I'm having trouble, working, or I'm having trouble sleeping at night. So that's what the HIV-specific stress measure is. So all of those constructs, those 3 constructs, went into our parental anxiety and stress measure. And we looked at that effect on parenting skills from a statistical modeling perspective. And the parenting skills here are the ones I described earlier in response to the very good question we had about what exactly are what makes up the parenting skills. In this case, we use the constructs of family routines, parent-child communication, and parent-child discipline. And so then the whole model is looking at then what effect does this have better your parenting skills, and that in turn affects what happens with your child down the road in terms of their aggression and acting out behaviors, their delinquency, their anxiety, their depression, etc. And in the model, we found that parenting stress was strongly associated, 0.96, with parenting skills, and also strongly associated with the child problem behaviors. So there are now established these direct links from a statistical and clinically significant perspective. So the moms in our study who were more stressed had less consistent discipline, so it varied in terms of what they did. And of course, many of you who work in this area know it's very important to have consistent discipline skills, because having inconsistent discipline usually leads to more child problem behavior. And they had, moms with more stress also had poorer parent-child communication, so they weren't as able to listen to their kids or to explain things to them, and they engaged in less frequent family routines. And I already talked about what a big impact having good, positive, stable family routines can have on the family. And then all of these, in turn, all of these skills had a direct negative association with child outcomes. So what does this all tell us when you boil it down? It tells us that we need parenting interventions for these mothers living with AIDS and HIV to kind of teach them and inform them about how their own distress can affect their child in the long run. So self-care becomes a way to take care of their children. A lot of our moms, and I don't know if you find this in your clinical work or your research, if you do research, a lot of our moms say, well, I'm busy taking care of my family, I'm putting them first, and I wind up not taking care of myself. And one of the things we found helpful is to let the moms know that actually is, they need to take care of themselves, because by taking care of themselves, they're taking care of their children. They also need strategies and support for dealing with their own distress, because it doesn't help to say, well, if you get distressed, your child's going to have worse outcomes. That just makes them more stressed if they don't know how to deal with their own anxiety and parenting stress. So in terms of getting social support, in terms of using all of the available programs that they may have available for them to use in their communities, and of course strategies to implement parenting skills. There are no courses in high schools about how to parent, and yet the majority of high schoolers go on to become parents. And we need to have more parenting skills programs, because a lot of our mothers don't even know some of the basics. They love to learn the communication skills. We found them very interested in learning the family routines and the parenting skills, but they often act surprised, like this is something they've never come across before. So those are the kind of implications from my research. And again, I'll stop for any questions right now. Nelson, are there any questions?
Thank you. As a reminder, to register a question, please press the 1 followed by the 4 on your telephone. And we do have a follow-up from the line of Chris Bezzoletti with Santa Cruz Community Counseling Center. Please proceed.
Yes, hi, this is Chris Bezzoletti, and I'm wondering if there have been any studies that show that implementing stress reduction programs actually help parenting skills. That's kind of a follow-on to this study.
That's an excellent question. There haven't been any related to parenting skills that I know of. There have been some stress reduction to see if you can improve adherence, not necessarily among mothers, just among women living with HIV. University of Miami has a group that focuses a lot on stress reduction and just looking at other outcomes like women's depression, etc. I myself have been thinking, since we got all this data, of trying to do a study where we look directly at parenting stress using biomarkers like cortisol, etc., and not just self-report measures, to see if by reducing parenting stress, we can improve mom's general functioning as well as child outcomes. So you're thinking right along the same way I'm thinking in terms of what maybe needs to be done next.
We also have a chat question parent-child communication and discipline?
I wish I could say that there was a really good one standard broad parenting skill measure that had clinical cutoffs that could be used both for research and clinical settings, but because I would certainly like to find one, but I haven't ever been able in all of my research to find a broad measure that I thought was really well validated and reliable. So I tend to use a mix of measures. I use a very good parental monitoring measure that was developed by Steinberg, Steinberg et al., that asks a lot of questions. You can ask either the child or the parent whether, like, you might ask the child, does your mom know where you are at night? Does your mom know what you do with your extra spending money? It gives you a good sense from both the child and parent perspective how well the moms are monitoring, and if the child believes the mom is monitoring as well as the mom says they are. There are good family routine measures available, and there are some good discipline measures, but they're all separate measures. And if anybody wants any of those research measures, any of my articles that are on this topic would have them in the reference sections.
Debra, would it be possible to get links to those articles that we can send out to our participants after this presentation?
Sure. That will give them a lot of reading to fall asleep to at bedtime.
Okay. And we do have a follow-up question from the line of Chris Bezzoletti with Santa Cruz Community Counseling Center. Please proceed.
You know what, I was thinking, have you compared your sample with non-infected moms? That way, like, compare and see where are the exact dysfunctionals on the moms that have HIV, because if you get a sample with moms that have poor parenting skills, you're going to get a lot of the same behaviors with children. They're going to start having, conduct disorder, they're going to develop stress, that they don't have a secure and safe environment. But that was my question. Have you done any comparisons to actually see a direct link to the HIV mom?
We have done direct comparisons of children of non-HIV infected mothers, since in my studies the main target of the research interest is the child and their outcomes. And there are differences. HIV tends to add a whole nother layer, so to speak, of complexity to the family dynamics and to the stress that the mom's experiencing, given that they're living with a chronic illness. So they look more like moms who have some type of chronic illness, like breast cancer or other types of chronic serious disorders, in terms of how they're functioning as a family and the outcomes, than they do normal moms that are just living in poverty situations.
Could you compare it to a mom that might have like a severe substance dependency?
I haven't used that particular sample. I've tended to use more physical illness because there's more parallels in terms of having to stick to strict medication regimens, having to have a certain number of follow-ups, monitoring viral loads. Those are all have comparable parallels in, for example, going through radiation treatment, following up with tamoxifen if you have breast cancer, etc.
My guess is that the caller is asking that because they predominantly work with a substance abusing population and is wondering if family routines and monitoring might be helpful for that population as well. Is that what I'm picking up on?
No, I just wanted to see what was the difference between HIV or any moms that have a severe physical illness versus moms that will not have that. What would be the difference in the behaviors, like direct differences versus a group that does not have that?
I think one of the main differences is the stigma attached to HIV and the stress that causes for the moms. And we've done one study where we looked at whether the children are aware of that. Actually, we did two, one when the kids were young and one when they were older, and whether that affects the child outcomes. And it does. Kids that are more aware of the perceived stigma are more protective of their moms. They're more concerned concerned about stigma by association. If their friends find out that the mom's infected, they might not want to be friends with the child anymore. So even at very young age, this was among our 5 to 11-year-olds when we did that study, we were surprised that children that young were so aware of stigma by association and didn't want anyone to know about their mom's infection because they were afraid they would lose friends or people would tease them.
What were some of the solutions or obstacles you found while doing your research with the moms? Did you have any problems with moms being open to cooperate with your research, or
no, our moms
kind of a monetary reimbursement to them, or anything that?
Our moms have been we have learned so much from our moms, and they have been incredibly open. They are very interested in helping, especially if they think this work, which it has, led to some intervention studies that will help other moms that are coming along in their footsteps. Our biggest problem in this sample was following moms back and forth across the border because they often would go down to visit family out of the United States and have trouble getting back in to the country, a certain portion of our sample. So we'd have to, schedule our follow-up assessments very carefully. Okay.
Any other questions on the line, Nelson?
There are no further questions.
All right. At this time, I'd like to turn the presentation over to Dr. Armistead.
Good afternoon. Debra, I enjoyed listening to your presentation, and I am struck by the overlap in our work, which I guess I would say is really striking me for the 5th or 6th time. I think what folks will hear today is a lot of similarities in the findings that Dr. Murphy reported with respect to those that I'm going to talk to you about today. And I think that the similarity in these findings really reflects and powerfully points to the need to focus on HIV-affected families. In other words, you'll hear about stressors these mothers and their children face, as you did from Dr. Murphy, and you'll hear about impacts on child functioning and impacts on parenting. And I think that the similarity in the findings really points to how critical it is to attend to these findings. So just to give you a brief overview of what I'll talk about today, I'll begin by addressing the context in which families affected by HIV live with respect to stress that they experience across biological, psychological, and social domains. Then I'll summarize some research that focuses on the impact of maternal HIV on child functioning. And this research is based on my work on the Family Health Project, which followed mothers living with HIV in New Orleans across a 6-year period, and the midpoint of that period was the time at which antiretroviral therapies were introduced, HAART protocols were introduced. So that shaped our findings in many ways. I'll also talk about linkages between HIV and parenting, challenges that mothers face. That information is drawn from the Family Health Project study as well. And I'll close with some intervention points that were identified from the Family Health Project, as well as intervention bringing in the other line of my research, which focuses on HIV prevention efforts using families, and in particular, family-based interventions designed to prevent the spread of the illness among youth. As you probably know, risky sexual behavior occurs at higher rates among adolescents whose mothers are living with HIV relative to those whose mothers are not. So let me just move forward here. So speaking first with respect to biological factors, the epidemiology of HIV in the U.S. has changed considerably since they first discovered the illness. And some of those changes are good, beginning with the fact that with the implementation of HAART, what we've seen is a dramatic decrease in the number of mothers, women and men, in fact, that are dying from the epidemic, as well as a decrease in rates of the illness. And so these lines that you see here, let me see if I can use this pointer tool to help illustrate some of this, see if this is going to work. Oh, yeah. So this line that you see here represents the decline in diagnosis in a plateau, although this peak is somewhat artificial because it's the point at which the AIDS definition was implemented. So you see a decline in diagnoses with a plateau here, and perhaps more relevant to this presentation, a decline in deaths. So the kinds of issues that mothers were facing in the early 90s and mid-90s, in fact, around permanency planning and coming up with alternative care as they approached the end of their lives, are now being replaced with, as Dr. Murphy talked about, issues around managing their health and their illness as HIV has transitioned to a more chronic rather than fatal illness. The other epidemiological variable to be aware of is the prominence of this illness in the African American community, and I'm sure you're all aware that proportionate to population rates, African Americans are much more impacted by HIV than other ethnic groups. Let me see if I can get back to, bear with me while I manipulate these slides. So just to recap with respect to biological factors, while a cure for HIV remains elusive, medications have resulted in HIV becoming a chronic rather than a fatal illness. And so we've transitioned in our interventions for families around parenting from permanency planning and fostering, et cetera, to interventions that emphasize mother's health maintenance as part of the parenting intervention, because a sick mother can't engage in parenting interventions if she's too incapacitated by her illness. Another important factor to remember is that even in the context of medications to manage the illness, HIV is characterized by periods of fluctuating health, so which can be somewhat unpredictable. So mothers might feel good for a while and then might experience periods of feeling much worse. And of course, her symptom level, including symptoms related to side effects of some of these medications, need to be taken into account when you're intervening with these families. So mother's health is essential to her parenting quality, which again you also heard from Dr. Murphy. Let's see. Do I need to double click on these slides to get them to pop up if I want to move a little differently? Amanda, do you know? Yes, it looks like it did. All right, thanks. In addition to managing physical symptoms, mothers living with HIV often contend with some psychological symptoms. In particular, rates of depression, depressive disorders, and anxiety disorders are higher among those living with HIV compared to those who are not living with HIV. And with respect to anxiety, you tend to see peaks at certain points of the illness. Of course, diagnosis with HIV being one of those peaks in anxiety. If a mother transitions from having HIV to actually being diagnosed with AIDS, you tend to see a peak in anxiety levels. So being aware of mother's psychiatric state and the extent to which she's experiencing depression and anxiety is particularly important as you intervene with families, because just like a mother who's ill has a hard time focusing on parenting, a mother who is depressed and incapacitated by that depression or anxiety can have a harder time focusing on enhancing her parenting. And likewise, some of the research from the Family Health Project demonstrated higher rates of trauma history among mothers living with HIV compared to their non-infected counterparts. So a history of trauma can result in outcomes like post-traumatic stress disorder, but even at a subclinical level, having this trauma history can impact a mother's ability to relate to her child or other aspects of parenting. And so it's probably wise, as you work with these families, to get a sense of the mother's trauma history and the extent to which any symptoms from that history, be it a history of child abuse, rape, etc., might be impacting her ability to parent. Of course, there are many social factors that result in stress for mothers living with HIV. most mothers living with HIV, as I think one of the participants pointed out, hail from the lowest socioeconomic bracket. They live in neighborhoods most typically that are characterized by a range of risks, high rates of violence, high rates of substance abuse, and other criminal activities. Additionally, although the stigma around HIV has decreased since we were first hearing about the illness, it still remains high relative to illnesses like cancer or other chronic or life-threatening illnesses that folks face. And so many mothers are dealing with multiple or even triple stigma or discrimination based on their disease status, perhaps their race, being a female in a male-dominated society, and other demographic characteristics. So in addition to or accompanying that discrimination based on multiple stigmas, you see sometimes an unwillingness to disclose their HIV status to friends or families. Most mothers don't tell most of the people around them, and often there are good reasons for that. But when a mother can't disclose that she has HIV, it makes it much more difficult to rely on family or friends to get the social support that could make parenting easier. And in our Family Health Project, when we compared social support from family and friends that was available to mothers living with HIV compared to mothers not living with HIV, mothers living with HIV reported lower levels of social support, both in terms of emotional support and the tangible support that they can get from family and friends. So it looks like I'll pause for questions now.
Nelson, we're going to open the line.
Thank you. Once again, to register a question, please press the 1 followed by the 4 on your telephone.
And Lisa, I had a question while we're waiting for callers to dial in. I'm wondering if you saw any differences in rates of stress and anxiety when broken down by ethnicity, given that there's sometimes these multiple layers of discrimination and stigma.
Well, it's a great question, but not one that I can answer because the mothers enrolled in the Family Health Project were all African American, so we weren't able to compare across race or ethnic group. And the other research that I've conducted around the impact of HIV on mothers has occurred in South Africa and focuses also exclusively on Black women. So it's not an answer I can provide. Debra and I have different samples, Debra's sample mainly being Latinas, and so it's an answer potentially that we could look at combining some of our data, but it's not an answer that I can give you based on my Family Health Project data, although it certainly makes sense in terms of multiple stigmas.
Nelson, are there any questions on the line?
I'm showing no phone questions at this time.
All right. If you'd like to continue, Lisa.
Certainly. So let me move to some outcomes. The Family Health Project, as well as research that I have conducted in South Africa, compared the children of mothers living with HIV to a demographically matched or similar control group. And so all the mothers enrolled in the study hailed from low-income communities that were characterized by some of the variables I discussed before in terms of poverty and crime, et cetera. So even when you're looking at families with multiple stressors, the children from families where HIV is superimposed on top of those stressors tend to function less well. So there is consistency across mine and Dr. Murphy's work demonstrating the link between parental HIV infection and child problems. And generally, we see problems both in terms of the internalizing domain, so higher rates of anxiety or depressive symptoms among the children of mothers living with HIV, as well as higher levels of externalizing behaviors, the acting out behaviors, getting into trouble, destroying property, etc. And when you look across research studies, the Family Health Project focusing on children from 6 to 11 over the course of 6 years, Debra sample being similarly aged, but then also when you look at samples following adolescence, you see that these problems persist across developmental periods, so from the very youngest to older children. You will see some variation in findings across studies. Sometimes mothers are reporting more difficulties in their children, and the children aren't reporting those difficulties, and then in other studies you'll see the opposite. So there is some inconsistency, but generally, if you collapsed across all of the research looking at child functioning in the context of maternal HIV, you would see higher rates of internalizing and externalizing problems. Within the Family Health Project, I should point out that while the average difference in children whose mothers are living with HIV relative to those whose mothers are not was statistically significant, the actual difference between the two groups of children was not dramatically different. So there are statistically significant differences, but at least within the Family Health Project, you aren't talking about a difference in 10 or 12 points on the child behavior checklist, generally speaking. And I think that reflects the environment that the control group was drawn from, which is the same as the environment that the mothers living with HIV were residing in, and that is inner city New Orleans, high crime rates, high substance abuse, and very limited resources. However, given the findings and the replication of those findings that we see across multiple studies, I think it's quite clear that mothers living with HIV and their non-infected children need support. Turning to the impacts on parenting, the parent-child relationship, many would argue, is the cornerstone of healthy child functioning. So the parent-child relationship provides the secure base from which children at all ages can go out into a world, and particularly for children whose mothers are living with HIV, a world that can be fraught with many challenges, socioeconomic challenges, discrimination, stigma, etc. So the parent-child relationship is fundamental, and unfortunately, across many studies, it's the variable that is most consistently reported to be disrupted by HIV. So in the Family Health Project data and in other studies, you'll see, certainly as well in my South Africa work, when you compare mothers living with HIV to those who are not on a measure of the relationship, the quality of the relationship, how well the parent-child communicate, how much they like spending time together, mothers living with HIV and their children tend to report a poorer quality relationship than the control groups. Beyond the parent-child relationship, physical health and medication side effects can impact the energy that parents have available for monitoring, supervising their children, maintaining family routines. So, again, similar to Dr. Murphy's work, family routines and roles can become disrupted. Children may experience developmentally inappropriate expectations. So the older children in the family may be expected to care for their younger siblings, or they may be expected to maintain family routines like cooking and sitting down to dinner and providing lunches for their younger siblings. And tending to these needs, taking care of their mothers, taking care of their siblings, might result in their being unable to attend to their own needs and engage in developmentally appropriate activities like routinely attending school, getting their homework done, having time to spend with friends, etc. So that role disruption can be an important intervention point. And then turning to the other line of my research, and relatively new with respect to the research horizon, is family-based sexuality education. So as I mentioned earlier, adolescents whose parents are living with HIV are at greater risk for negative sexual health outcomes, unwanted pregnancy, STIs, etc. And relatively new research is indicating that parents, and by parents I mean not only parents that are HIV infected, but parents more broadly speaking, are uniquely positioned to provide developmentally sensitive and culturally competent sexuality education to their children, And yet, as you probably know, most parents, again, regardless of HIV status, don't provide this kind of education to their children. They rely on sexuality education offered in schools, by the media, or from children's peers. Providing sex education to your kids can become more complex or be more complicated in the context of HIV, given the transmission routes of the disease and the stigma that remains associated with HIV. Parents living with the virus may have a more difficult time with this process than healthy parents do. And generally speaking, it's difficult for all parents, but when you superimpose HIV on top of this, it can become more complicated. So let me move next to some of the intervention targets identified in the research. As I've said before, interventions that foster and enhance the parent-child relationship in the context of HIV are needed. There aren't many out there. Dr. Murphy's work is one of the few empirical evaluations of a parenting intervention that targets the relationship, focus on communication, etc. I think that interventions specific to mothers living with HIV are critical, but I also think that adaptation or reliance on empirically supported interventions for families without an illness, such as parent-child interaction training, may be beneficial, particularly in the absence of empirically supported interventions that focused on HIV-affected families. And again, not to beat a dead horse, but I don't think we can understate how important it is to attend to mothers' health management issues. If mothers are not taking care of themselves and are not helped with respect to taking care of themselves, they're not told or provided strategies with regard to taking care of themselves, then it's just not feasible that they can be taking care of their children. So any parenting intervention needs to tend to maternal health management issues as well. The two intervention pieces that I want to spend a bit more time on are the parent-child relationship piece as well as the family-based sexuality education piece, in part because it's where my interest lies, but also because I thought it might offer something that doesn't overlap quite as much with Dr. Murphy's work. So beginning first with the parent-child relationship, without attention to this factor, interventions around consistent discipline, monitoring of children's behavior are not going to be as effective. So a warm, nurturing relationship between parent and child appears to be pretty fundamental to other aspects of parenting. If the relationship is disrupted, then many children aren't motivated to listen to what parents say with respect to how they should behave or to share where they're going, with whom they're going, and what they're doing with regard to monitoring. So getting this parent-child relationship in place seems to be critical, and Dr. Murphy's IMAGE program focuses in part on this, particularly with respect to communication. I think that one of the pieces that's critical and often overlooked with respect to parenting interventions in general, but probably with particular respect to the parent-child relationship, is culturally tailoring these interventions. So it's critical to consider a family's culturally based perspectives on parenting as you intervene around parenting. In other words, you can't use a cookie-cutter approach across families. Cultures differ with respect to the level of autonomy that children are allowed, the extent to which the parenting style is authoritarian versus authoritative, the boundaries between parent and child, involvement of other adults in the child rearing process, and all of these factors need to be taken into consideration, either at the larger empirical level, but also at the day-to-day level. It's important to partner with families around the ways in which their culture speaks to them about the parent-child relationship and parenting more generally. I think you lose parents when you start trying to globally apply too much to their lives. And then, of course, the child's developmental stage is critical to tailoring interventions. So going back again to the parent-child relationship, one fundamental piece of that is increasing or enhancing the positive time that children and parents spend together. And while this, you could argue, would be a goal across any developmental phase, the strategies for increasing the positive time that parent and child are spending together is going to differ depending on whether the child is 6 or 16. So you're not going to get down and have floor time with a 16-year-old like you might with a 6 or 7 or 8-year-old, but you would rather try to intervene around the way that mother is talking to her 16-year-old. I think fundamental to many interventions around the parent-child relationship, again, across age, although you would tailor the specifics of the intervention, include increasing the time that parents and children are spending together. This was a part of an intervention that I'm implementing now in South Africa. And one of the things that we heard from many mothers there, which I think easily applies to mothers here, being a mother myself, it certainly applies to me, and that is that it's hard to carve out special time with your child. It's hard to think about spending 30 or 40 minutes uninterrupted, even a day, with your child. And so spending some time problem solving or brainstorming around how to incorporate time together into daily activities. I keep trying to convince my children that it's fun to do chores if we do it together. They haven't totally bought that, but I continue to work on that because I have stuff that has to get done, and if we can spend the time cooking the dinner together, then at least it's time that we're together. Other pieces fundamental to the relationship are good communication and helping parents learn how to listen to their children, how to reflect back what they believe that they hear, and how to convey to children that you notice when they're doing well. We spend a lot of time catching children being bad, but working to catch children being good and communicate that praise or reinforcement to children can be a real boost to the parent-child relationship.
And Dr. Armistead, before you move forward, even though it's not indicated in the slide, I was wondering if you would be open to opening the line up for questions?
Certainly.
We do have some chat questions that are coming in, and I'm wondering if there are other people who would like to call in their questions. So, Nelson, if you don't mind opening up the line.
Thank you. As a reminder, to register a question, you may press the 1 followed by the 4 on your telephone.
And we do have a question, and please forgive me if I mispronounce your name, from Myrea Herrera Bayard, and she asks, was the spiritual element or foundation used in any way as a stress measurement for mothers?
In both the Family Health Project and my work in South Africa, we assessed spirituality and religiosity among our mothers, and thinking that perhaps, as you're pointing out here, it could be a resource, a buffer for mothers. And we did not find that religiosity had a significant impact on parenting quality or on child functioning, but I suspect that that's because the vast majority of the participants, both in my South Africa work and in my work in the States, report very high levels of religiosity and spirituality. So it's clear that for the vast majority of the women enrolled in these studies, spirituality is a big part of their life and indeed appears to be a resource as I think back on the qualitative work that I've done with some of these families. But when you don't see variance across your sample, so when most of the mothers are reporting high levels of spirituality on your measure of spirituality and religiosity, you can't find effects for that particular variable. So while I would say that my data, what I would say about that is that my data don't really allow me to look at the extent to which that factor buffers or protects families.
Dr. Murphy, were you able to assess that at all?
Oh, we did early on when the children were younger. We assessed religiosity, and we also we ask the kids things like, how often do you go? We have very basic, concrete questions. How often do you go to church? Do you like going? And we assessed it from the mom's perspective. We did a brief conference presentation on that once, and our findings were very similar to Dr. Armistead's. It did not affect the parenting skills per se, although it did seem to be a source of support for the moms.
We have another question from Julieta Hernandez who asks, are there any studies on parenting among HIV-affected families in early childhood?
So the youngest children in my sample were 6, and I don't know of work before then. I don't know if you might, Debra.
No, my earliest are usually, we had a one or couple 5-year-olds, but we were 6 like you were, school age. Because to get the kids to report their own feelings, you kind of have to be around that age. If you go younger, you don't get reliable reports. But I don't know of any. There's a lot of general population infant studies in terms of parent-child attachment and bonding. I've never seen that done for families affected by maternal HIV.
Nelson, are there any calls on the line?
I'm showing no questions over the phone at this time.
Okay.
Okay, I'll move forward.
Great.
So let me turn to family-based sexuality education, which may not be on folks' radar, and what I will present will be a somewhat limited synopsis, perhaps, of the work that I've been doing here and in South Africa. So I've been involved in 2 studies that are aimed at helping parents provide sexuality education to their children. The domestic project, which is the Parents Matter program, didn't specifically target mothers living with HIV, but many aspects of the intervention are likely to apply to these families. In South Africa, we have developed an intervention that incorporates the complications that HIV may bring into the process of promoting sexual health among adolescents. That project is called Mbado Akaya, and it is a Xhosa word that means conversations in the home. Both of these interventions focus on some general parenting factors that we've already talked about, monitoring parent-child relationship, but they weave in, backing up just a bit, they focus on general parenting in large part because these variables have been associated with healthier child outcomes with respect to sexuality and lower rates of STIs, etc. But the other fundamental portion of these interventions is helping parents and children communicate around sexuality and sexual health. So both interventions aim to provide parents with the knowledge, skills, comfort, and confidence to address sexual issues with their children. These interventions include the notion that sexuality education should be a lifelong process, beginning from birth and moving forward throughout the child's life. Of course, I say that knowing that you target developmentally what you talk to children about with respect to sexual health. So what you say to a 6-year-old child about sex is going to differ considerably from what you say to a 16-year-old child. But the importance is to try to open up those lines of communication early on because the data clearly indicate, again, across studies, that youth who can talk to their parents about their sexual health, who can come to their parents when they're struggling with an issue, tend to have much healthier relationships. So they tend to initiate sexual activity later, and they tend to practice safe sex when they do initiate sexual activity. Some of the benefits of trying to use families, again, especially in the context of HIV, to impart sexuality education is that the education can be child-driven. So your children can let you know what they want to hear or what they're ready to hear. And parents are much better able to gauge that readiness than than a classroom teacher who's got to provide a standardized curriculum to children was able to do. So my younger child, who's 10, is much more curious about sexuality and asked me early on, where do babies come from, and has asked that question 2 or 3 different times from the time he was 3 until the past year, each time getting a little bit more information from me and being interested in hearing a little bit more information as compared to my 13-year-old who from the start really didn't want to know about that gross stuff and still doesn't seem to want to know or gets much more embarrassed than our 10-year-old. So parents are really able to tailor information to their children's comfort level. By the same token, many parents talk about wanting to provide this information to their children, and when you ask children who they want to learn about sex from, the most common response is mothers. When you ask those same children where they learn about sex from, the most common response is friends or television, which is generally not where we want children getting information about sex. And the third benefit of family-based sexuality education is that parents are given the opportunity to identify and impart their values about sexuality. So you may or may not be aware of the wars, for lack of a better word, around abstinence-only education versus comprehensive sexuality education, and the government's values around that, or the media, what the media presents with respect to those notions. And so what the premise of the Parents Matter program, as well as my work in South Africa, is that it should be family values generally that are imparted to children and not values determined by the media or peers. So if you embrace, or if you can imagine trying to convince families to be the primary source of sexuality education for children, you're likely to encounter from all parents, regardless of HIV status, a good bit of embarrassment, a good bit of discomfort. Many of us grew up in families where sexuality wasn't discussed at all. So it's overcoming that discomfort is pretty consistently a barrier for all parents, or most parents. For parents living with HIV, fears around having conversations about sexuality, forcing disclosures either around their HIV status or around how mommy got HIV, if the child knows, did it have something to do with sexual partners, number of sexual partners, etc. So when you talk to mothers living with HIV, and we've done this in both South Africa and qualitatively here in the States, I hear two kind of distinct camps with respect to these mothers. Some saying that because they're living with HIV, they embrace the notion and work hard at being the primary sexuality educators for their children because they have a powerful message that they want to send about staying safe and not contracting HIV. And then the other camp of mothers who typically haven't disclosed their illness, or if they've disclosed their illness, there's not an open communication between parent and child around the illness, and they worry that any conversation about sexuality will lead to conversations about HIV, which may result in unintended disclosures. A lot of parents believe that if they talk about sex, adolescents will hear that as permission to have sex, and the data consistently refute that myth that conversations about sex encourage adolescent sex, and that parents whose children talk to them about, children whose parents talk to them about sexuality tend to engage less frequently in risky behaviors than children whose parents don't. Many parents will report that they don't have any confidence in their ability to have these conversations. Either they don't feel like they have the knowledge they need, or they weren't provided models growing up on how to have these conversations. And parents get nervous about the notion of the big birds and bees talk, the one big talk. And what we try to reiterate in our interventions is that it shouldn't be one talk, but rather a series of small talks throughout, again, the course of the child's life. So some Tools that we provide parents around in our interventions include helping parents listen to what the child is saying more than they talk. The emphasis on wanting to be a responsive listener so that the child feels safe and feels like they have permission to come to parents with questions. Parents tend, especially around sexuality, to kind of fall into a lecturer mode where they're sending messages in one direction as opposed to communication being back and forth. So we encourage and teach listening skills. Using teachable moments. So I'm dating myself with this, but I've watched Friends with my children, the show Friends, and was initially kind of taken aback when I realized that this was the episode on reruns where they were going to talk about condoms, and then thought, well, this is a good time to talk about condoms. So seizing the moments via the television or the billboards that you drive past to provide your parents' values and parents' notions of what's important with respect to sexuality to their children. And then within interventions, and this applies to any parenting intervention, but using modeling and role-playing. Social learning theory clearly tells us that practicing what you're going to say or practicing what you need to do results in better learning. And interventions that incorporate modeling and role-playing are likely to be more effective than those that don't. With regard to that, one of the neat things that we do in both of our interventions is to have parents and children switch roles. So we bring children into some of our sessions with parents and have the children play the role of parent and the parent play the role of child. Not always talking about sex, but just generally trying to communicate with one another. And you get an interesting sense of how parent and child perceive one another in those interactions. So you get parents, I think mothers in particular, get a clear sense of how their child perceives them as a communicator, and that sometimes can shift or motivate a parent to shift the way they speak sometimes to their children. Another important piece of sexuality education is providing strategies for avoiding peer pressure, teaching children how to say no and still stay cool or still be accepted by their peers. And again, relying on modeling and role-playing as you teach children these strategies, or as mothers and fathers teach children these strategies. So providing particular words for the child, or helping the child generate words around what she or he would say if a peer offers her alcohol or some other drug. And I think I'm again at the point of questions.
Nelson, can we open the line again?
Thank you. To register a question, please press the 1 followed by the 4 on your telephone.
And we do have a chat question from Myrea, who asks, and I believe you touched on this briefly, but in the sexuality education, have you seen a difference between mothers who disclose their illness to their children and mothers who do not disclose?
That's a fabulous question, and I wish we had the data to look at that question. What we're doing right now in South Africa, which is the context in which we're assessing for and including families affected by HIV, we're at the pilot phase, so we have only 90 families, which doesn't allow us to look at within the group of mothers living with HIV, those who have disclosed and those who haven't, at least quantitatively. There just aren't enough mothers enrolled at this point. But should we get some promising findings with this study and roll out a larger trial, I think that will be very important to look at. The intersection of disclosure and sexual health education, I think, is very important. And I don't know of any work to date that has looked at those differences. I think it's very important, though.
There also seems to be an interest from participants to receive links to both of your studies, both yours and Dr. Murphy's that were mentioned today. Is that something that we would be able to provide after the presentation?
Absolutely. Sure.
Wonderful. Nelson, do we have any questions on the line?
I am showing no questions at this time.
Okay.
I will move forward to my conclusions. think the things that I've tried to highlight here is that parenting is a challenge, and certainly when people are parenting within resource-poor and risk-rich environments, it's particularly challenging. Certainly those living with HIV face a variety of challenges that they could use help around. We know that children whose parents are living with HIV tend to function less well, and parents are uniquely positioned to mitigate or buffer some of the negative effects of their illness, but they have to be supported in their efforts via interventions or changing the landscape with respect to stigma and discrimination. I've also tried to touch on the importance of tailoring interventions to your family's culture, as well as, of course, the child's developmental stage.
Wonderful, thank you. I think at this point we're going to open up the lines one final time, and if you have any questions for either Dr. Armistead or Dr. Murphy, now would be the time. So Nelson, just one more time to open that line.
Thank you. Ladies and gentlemen, to register for a question at this time, please press the 1 followed by the 4 on your telephone.
And just for your reference, we have produced in-house a research to practice brief that deals with working with these children who are HIV negative but have an HIV positive parent and may be experiencing some of this parentification, which was touched on earlier, taking on developmentally inappropriate roles, providing routine, providing caregiving for siblings, things like that. We have developed this in-house brief for best practices for working with these children, and that will be available on our website in the coming weeks, if you'd like to keep an eye out for that.
And it's very good. I've read it.
Thank you, Dr. Murphy.
I'm showing no questions at this time.
Okay. Any final thoughts for either of you?
Not from me, except for that I'll say I appreciated hearing some of the questions. It's certainly given me some ideas about moving forward.
Wonderful.
Yes, I hope this was helpful.
Well, thank you both for sharing your time and your information. As always, the presentation will be available on our website in the coming weeks. We'll also be including those links to the studies that were mentioned today, so you can look over those at your leisure. When we finish here, a pop-up will show up for a brief online evaluation form. We'd love to get your feedback. If you happen to be listening in a room with many users, there's a link so that each person in the room can provide feedback to us. We do honestly and sincerely look at that and implement it in future webinar series. With that, thank you to the presenters and to all of those who have participated. As a reminder, the next webinar training, entitled Addressing Poverty as a Risk Factor in Child Neglect, is scheduled for September 14th at this same time, 10 a.m. Pacific Standard. In addition, if you'd like to register for our hands-on skills building on domestic violence, entitled Hope for the Future, Ending Domestic Violence in Families, which is scheduled for September 21st and 22nd here in Berkeley with Alice LaViolette, registration is still open for 2 more weeks. You can visit our website at www.aia.berkeley.edu for more information. Thanks again, and have a wonderful day.
Ladies and gentlemen, that does conclude the conference for today. We thank you for your participation and ask you please disconnect your line.